Hello, welcome to Atropia Medic School. If you need help with questions from your EMT coursework, this is the place to be. Like and subscribe, and let's get started. Today we're going to go over respiratory distress and respiratory failure questions, so let's get at it. So, first question, you have an alert patient with peripheral cyanosis and pursed lip breathing. The patient is tachypnic as well. You should A, administer high-flow O2 via non-rebreather mask. B, administer BVM ventilations. C, call for ALS. Or D, assist the patient with their own inhaler. So, we'll give it a second to pick an answer. And if you picked administer high flow 2 via non-rebreather mask, you'd be correct. There's a few things here telling us that this is a good answer. First, alert patient. This is not to say that an alert patient couldn't go into respiratory failure, but chances are they're oxygenating well enough to get their brain the oxygen it wants. Peripheral cyanosis doesn't necessarily tell us respiratory failure, just tells us they're having some issues oxygenating. Pursed lip breathing is also a very common thing for patients with respiratory distress or breathing problems to have. This helps create some back pressure to keep the alveoli more open. They also mentioned that the patient is tachypnic as well. This tachypnic just means, or tachypnea, we can spell, I swear. Tachypnea just means fast breathing or an elevated respiratory rate. It doesn't necessarily tell us that the patient can't breathe on their own. They're just having some problems breathing. They don't give us vital signs. That's okay. We don't need that to answer the question. Let's give them a bunch of O2 to see if that helps improve their symptoms. Again, an alert patient with these more generalized signs or symptoms of respiratory distress is more suggestive of we just need to oxygenate them better as opposed to we need to do the work for them. Something to note here from a test-taking perspective, most test writers know that you're going to call ALS anyways, because remember, that's all the way in the beginning of your patient assessment with scene size up. That said, they know you're gonna call them. They're not testing you on whether or not you're going to call them. They're testing you on, do you know what to do in the meantime while you're waiting for them? The other thing to keep in mind is we don't have enough information here to say, let's give them an inhaler, let's assist them with their own inhaler. We have no history, we don't have lung sounds, we don't have vital signs. I'm not comfortable giving them any medications until I have a better idea of really what's going on. So this is a good example of a patient that has respiratory distress and we just need to oxygenate them better. Cool, let's move on to the next question. So you have a 6-year-old with worsening mental status and rapid shallow respirations. You should A, administer high flow O2 via non-rebreather mask. B, administer BVM ventilations. C, initiate chest compressions. Or D, administer CPAP. Take a second to pick an answer. And if you picked administer BVM ventilations, you're correct. There's a few things here telling us that this is definitely respiratory failure. And let's write that down here. This is a good example of failure. First things first, they are worsening in mental status over time. When I have a respiratory issue and over time their mental status is slipping, that tells me they can't oxygenate or ventilate to the point where their brain is starving for oxygen. Their brain is going offline. Another thing to note is rapid shallow respirations. This combination of language is highly suggestive on most tests that the patient's in respiratory failure. Whenever we have respiratory failure, what does that mean? That really means that there's a inability to ventilate combined with some sort of inability to adequately oxygenate. So we have an inability to ventilate, inability to oxygenate, some combination thereof. And at this point, we got to do the work for them. If the patient can't do it on their own, we need to do it for them. Compare that with respiratory distress, where there is some sort of disruption in the proper ability to oxygenate and ventilate, but the patient is compensating for it. So a couple things that we can do here. If it's easier sometimes to eliminate answers because you're not sure what to pick right off the bat, that's okay. You can get rid of answers. That's sometimes easier. They don't mention anything about cardiac arrest or the heart rate being under 60 or anything like that. You can get rid of C. We can talk at some other point about when do we do CPR in children. Discussion for another time. We talked about how this patient is clearly in a respiratory failure. They need more than a non-rebreather mask. We need to do the work for them. CPAP is a fantastic tool, but there's some contraindications you need to keep in mind for CPAP. So, big X. First off, hypotension. The patient cannot be hypotensive because this device will drop their blood pressure down more due to increased intrathoracic pressure. The patient has to be able to follow commands. I'm not saying that they may be 100% completely with it, because if I had respiratory distress, I'd probably be panicking too. But if they can't follow basic commands, I can't coach them into using it. Even if I was allowed to use CPAP in a pediatric patient, and most systems don't let their EMTs or paramedics use it in pediatric patients. But even if I was, their worsening mental status, that's not a good fit. The chances are they're not going to be able to follow commands. The other thing to keep in mind is chest trauma. Not relevant here, but any patient with chest trauma should not get CPAP, because I can pop a hole in the lung, or if they already have like a pneumothorax, I could make that worse. So to circle back on a couple things here, when we have failure, we can't just simply oxygenate them out of the problem. We have to provide those BVM ventilations or mouth to mouth or whatever. CPAP is also not a solution for respiratory failure. We have to use the BVM ventilations. One other thing I want to go over here is, what's some other language that tells me respiratory failure is the case? Failure language. There is some common language that they may throw on your test that tell you that the patient's in respiratory failure. So we just talked about rapid. Oh gosh, I can't write today. We just talked about rapid and shallow, and especially in that combination, definitely kind of concerning for respiratory failure. What else? If they use the words intermittent or irregular, those are also concerning words for respiratory failure. If they use the words agonal or apneic, obviously that patient is not breathing effectively on their own. And something to note here, this is where you need to check for a pulse. Check for a pulse, because they may be in cardiac arrest at that point, and you need to pick up on that very quickly. Last but not least, if they give you in adults a respiratory rate of 30 or above, or a respiratory rate of 8 and below, those are some pretty hard numbers to go off of, telling you, hey, I need to ventilate this patient. They're not doing it effectively on their own. So again, respiratory rate of 30 and above or 8 and below, think about, hey, this patient can't ventilate on their own. Let's just do the work for them. Sweet. Let's move on. Next question. You have an alert 20-year-old patient with intercostal muscle contractions and expiratory wheezing. The vital signs are heart rate 100, BP 120/70, respiratory rates 26, and the SpO2 is 95% with high flow O2 with non-rebreather mask. And they are still symptomatic. You should, A, administer epinephrine 0.3 milligrams 1 to 1,000, B, administer BVM ventilations, C, administer bronchodilator nebulizer, or D, continue with the non-rebreather mask. So take a minute to think about your answer. And if you said administer the bronchodilator nebulizer, you would be correct. So this patient is certainly in distress. Why is that? Well, a few things. One, alert. So they're clearly oxygenating well enough in order to keep their brain happy with the amount of oxygen they're getting. Some language here: intercostal muscle contractions, expiratory wheezing. These are some signs and symptoms of just having difficulty breathing. That doesn't necessarily tell us that the patient is in failure. We just saw the language that they might use for failure. This patient's alert. They don't have a slipping mental status. There's clearly some visible signs that they're having trouble breathing. So given all that, we can probably comfortably say they're in distress. When they give you vital signs tell you a couple things. Most test takers don't just give you vital signs for giggles. They're telling you you either can do something, you can't do something, or there's something going on you need to address. Note how their respiratory rate's 26. This is an adult, so that's fine. They're tachypnic, but they're not in failure. And with the O2, guess what? They're oxygenating okay, right? They have a good SpO2. So this isn't necessarily a failure to ventilate or oxygenate at this point. They just have respiratory distress. When we say expiratory wheezing, we're thinking of that musical sound, especially when we listen to their lungs, usually a little bit lower down or in the middle fields, usually bilateral, very suggestive of things like asthma or COPD, depending on what's going on with them. So this patient may very well have one of these reactive airway diseases going on. So when they give me vital signs, that tells me I can start considering meds, right? So we can start considering meds here. Now keep in mind with vital signs, sometimes the vital signs are not great and they're telling you, hey, you can't use some medication, but heart rate of 100, not terrible, nothing to write home about. BP's fine. They've got the expiratory wheezing, probably have a history of this going on, although we can't necessarily 100% state that that's the case, but chances are they probably have something along the lines of asthma or COPD going on. A is not an appropriate medication for asthma or COPD, at least at the EMT level, for test-taking purposes. In real life, we may very well use epinephrine as a bronchodilator, but for most test-taking purposes, we're going to consider epinephrine really for anaphylaxis. And this patient doesn't seem to be in anaphylaxis. This patient is not in failure, not in respiratory failure. We don't need to pull out the BVM. And when they give you, continue with the same intervention, even though it's not necessarily fixing the issue, you can probably get rid of it because they're not testing you on, do you know, to continue oxygenating them. The test takers or the test writers know that you know that. Instead, what they're testing you on is, do you know what the next step is when this first intervention is not working? And so this is where we can build on, okay, we've got expiratory wheezing, they have respiratory distress, we aren't oxygenating them out of the problem, so why don't we do a bronchodilator? So at the EMT level, right, we're thinking albuterol. A little bit about albuterol. It's a beta-2 agonist, meaning it activates beta-2 receptors in the bronchi and bronchioles, dilating them out. Hence why it's called a bronchodilator. Couple things to note here. So some side effects. It will make your heart rate go up because it will bind to some of the beta-1 receptors in the heart because it'll get absorbed into the blood. It may increase anxiety, palpitations, things like that. May increase their blood pressure a little bit. So just keep that in mind when you give it to them. You always want to warn patients of the side effects that might occur. There's not too many hardcore contraindications, but to keep in mind, if the patient is in congestive heart failure, this is probably not a good medication to give them. Even if they're having some wheezing, we're stressing out the heart more by giving them this beta-2 receptor agonist. And their heart's already struggling as it is. You may worsen some of their symptoms. I'm not saying you'll kill them, but you may worsen some of their symptoms. It's not good medicine to give something that we know is going to kind of, it may have a benefit, but it may very well make some of the problems worse. Something else to keep in mind, when you have a heart rate of like 130 to 150 or above, you may need to consider you may need to consider this as a cardiac problem, and they're getting some wheezing induced from the cardiac problem. So a lot of textbooks will say if their heart rate's like 130 to 150 or above, you need to really think about this more potentially as a cardiac problem, a dysrhythmia or whatever, rather than a breathing problem. But the heart rate's 100, right? If I was having difficulty breathing, my heart rate would probably go up too. So, all right, next question. A 60-year-old male with chest pain and shortness of breath is noted with eupnea and is acyanotic. You should, A, administer aspirin 324 milligrams orally. PO stands for orally. I'll write that down. Oh gosh, I can't write. Answer B is administer a nasal cannula. Answer C is administer high flow O2 via non-rebreather mask. Or D, administer nitroglycerin 0.4 milligrams sublingual. Sublingual. Take a moment to think about your answer. And if you picked administer a nasal cannula, that is a great start. So, we don't talk much about when do we use a nasal cannula versus a non-rebreather mask. If I have clear, visible signs of respiratory distress, visible respiratory distress, that's when I pull out the non-rebreather mask, is when it's very obvious, like, oh, you're having trouble breathing. We talked about some of the language we see pop up. Pursed lip breathing, intercostal muscle contractions. You can also see the muscles in their neck, like the sternocleidomastoid muscles in their neck. A lot of times patients with difficulty breathing may be using those accessory muscles. So keep that in mind for when I want to use a non-rebreather mask. Going back to the question here, they say, yes, shortness of breath, but you note eupnea, and they're acyanotic. So cyanosis, that's that bluish color that you might see in the skin when the patient has a low O2 levels. Well, we don't see that here. Eupnea, EU as a prefix, means normal. Means normal. So when they're saying that they have eupnea, it means they have normal breathing. So this patient has otherwise normal breathing, doesn't look cyanotic. Why should I try to hyperoxygenate this patient, giving them way more O2 than they probably are going to know what to do with physiologically? Doesn't make sense. So this is a great place where a patient may tell me they have shortness of breath. Sometimes they may have tachypnea, sometimes they don't, but there's no clear other indications that they have very significant respiratory distress. Nasal cannula is a fantastic way of going. Something else to note, we have no numbers, right? So if they had vital signs, that could give us a better idea of can I get away with the nasal cannula, or do I need to go to a non-rebreather mask? That part's not so important here. Again, we have someone with otherwise pretty mundane findings. Another thing to note, there's no vital signs. If I don't have vital signs, we should be a little uncomfortable just throwing out medications, especially nitroglycerin. Remember with nitroglycerin, one of the things it does is it lowers the blood pressure. So you definitely need a blood pressure before you give it. Usually, the blood pressure needs to be at least 90 to 100 systolic. The test takers will either give you something well below or well above this systolic value, so you don't have to worry about the range so much. But do know that if I without vital signs, don't be giving nitroglycerin. Without more information, I would not be giving aspirin either. Again, we're here in the primary assessment, right? This is the primary assessment. And when we're in the primary assessment, we got to fix the primary assessment issues, right? Your ABC life threats. So always keep in mind, where am I in the assessment when I'm getting these assessment type questions? Sweet. Last but not least, you have an anxious patient with a flail segment and significant pain. You know a respiratory rate of 34 and shallow breathing. You should, A, apply pressure to the flail segment, B, administer high flow O2 via non-rebreather mask. C, assist with BVM ventilations. Or D, call for ALS. So take a moment to think about the answer. And if you picked assist with BVM ventilations, you're correct. So again, if you're having trouble just simply picking out the right answer right off the bat, and that's totally fine, you can absolutely try with getting rid of some answers you know make no sense. We talked about how D, call for ALS. They know you're going to call for ALS. They're trying to figure out, do you know what to do next? Now, there's some language here that we need to pick up on. Anxious patient, okay. I mean, if I had problems breathing, I'd be anxious. They mention a flail segment. We'll come back to why that's important in a minute. Significant pain, okay. Yeah, if I broke some ribs, I'd be in pain. Rate of 34, respiratory rate of 34, and shallow breathing. Ooh, there's some language we saw, right? If we had a respiratory rate of 30 and above, we had a respiratory rate of 30 and above or 8 and below, we know that that's respiratory failure. And we also talked about how shallow breathing is another thing we need to be on the lookout for. They didn't say rapid, but a rate of 34 is pretty rapid. So this patient they really are in failure. They may not be completely, under the bus quite yet, but they clearly are having some major issues. Right. So how do we solve that? Well, we're going to solve that with BVM ventilations. Generally speaking, don't just apply pressure to a pretty significant injury, and we're not going to be able to out-oxygenate this problem. Now, why is flail segment really important to know here? Aside from some of the other language used, when it comes to flail segments, they have what we would call paradoxical chest wall motion. That's sometimes a term that is used on tests. Paradoxical chest wall motion. Meaning when the patient is breathing in, so their chest wall is going out, trying to fill their lungs, because the inside of your chest is negative pressure, it's like a suction cup, that flail segment's going to get sucked in. And remember, flail segment is going to be 3+ ribs broken in 2+ places. That's what a flail segment is. So we're going to have paradoxical chest wall motion. So when they exhale and everything goes back to its original shape, we're increasing the pressure inside the chest doing that, and the flail segment is going to pop out. This can be super painful. So if I do positive pressure ventilation, meaning I push everything out at the same time, I push air into their lungs and push everything out at the same time, positive pressure ventilation. I'm using my hands to describe stuff, and you can't see what my hands are doing, so I apologize for that. But if we use positive pressure ventilation to push everything out at the same time and allow everything to recoil back at the same time, that can really potentially reduce a lot of their pain, allow us to get more full ventilations, and generally improve patient condition. So this is where we're going to have to do quite a bit of coaching. You may have to coach the patient quite a bit into accepting the BVM ventilations, allowing us to kind of breathe more for them, kind of giving up some of that. That may be a pretty big leap for a lot of patients, so just keep that in mind. But from a test-taking perspective, when I have a flail segment, BVM ventilations are probably the thing that you should be picking up on as an answer when you look at those questions. That's all I have for today. If you like the content, like and subscribe, and we'll see you next time.